Next speaker is Dr. Patty Garcia from Stanford. She joined the faculty there about 3 years ago and is now the director of the GI Motility Lab. In addition to seeing motility and functional bowel patients, she also spends a large portion of her time doing clinical informatics work and serves as the medical informatics director of the ambulatory specialties. And today she's going to be talking about how to treat some of our most difficult functional and IBS patients. Obviously, a very challenging topic, and I look forward to hearing her insights. Thank you.
Okay, thank you. Hopefully you guys can hear me and see my screen. I'd like to welcome everyone back from this short break and thank the NCSEG for inviting me to share some tips for treating your most difficult functional and IBS patients. I'm going to share my first tip with you by changing the title of my talk to what you see here, to tips for treating your most difficult patients with disorders of gut-brain interaction. The word functional was originally meant to differentiate conditions in which no structural abnormalities were identified, but over time the word has come to mean psychosomatic. And we know that the majority of functional disorders are not psychosomatic, and in fact are related to perturbations in gut-brain communication, hence the new term, disorders of gut-brain interaction. The patients I'd like to talk about today are those who've had an otherwise normal workup, but continue to have a significant symptom burden. For some patients, that may mean weight loss and visits to the ER. For others, that may mean frequent phone calls to your office and a significantly impaired quality of life. These are also the patients who've tried and failed a range of diet and lifestyle suggestions, as well as first-line over-the-counter and prescription medications. So I'd like to start by talking about patients with, for lack of a newer term, functional dyspepsia. So one of the underlying mechanisms of functional dyspepsia is likely poor gastric accommodation. Gastric accommodation refers to the relaxation of the proximal stomach after eating, which allows for an increase in gastric volume without a concurrent increase in pressure. Buspar is a 5-HT1 serotonin partial agonist that historically has been used as an anxiolytic. But in terms of its GI effects, activation of these serotonin receptors on cholinergic nerve endings leads to relaxation of the smooth muscles that make up the proximal stomach. There have been a few trials looking at Buspar for the treatment of functional dyspepsia, and what I'm showing here are figures from a study done by Jan Tak and colleagues in 2012, where they randomized 17 patients with functional dyspepsia to Buspar versus placebo. They found a significant improvement in overall dyspepsia severity, which is up here, and they also found improvement in meal-related symptoms like fullness, bloating, belching, and nausea. I'm not showing the data here, but they also found that buspirone improved gastric accommodation, which they measured using Iberogast. So the bottom line is that buspirone tends to be very well tolerated, with the main side effect being sedation, which is dose-related and often improves with time. The typical dose that you're targeting is about 30 milligrams a day. So in the trial, it was 10 milligrams TID, but you can start with something like 10 milligrams at night, then maybe add 5 milligrams in the morning, then maybe try 10 BID and kind of slowly work your way up from there. A non-prescription alternative for functional dyspepsia is Iberogast. So while many of us often reach for FD Guard because it's sold at CVS and it only has 2 ingredients, which are easy to remember, those are peppermint oil, which is antispasmodic, and caraway, which helps with gastric accommodation, Iberogast may be an even better choice. So this is a combination of 9 herbal extracts, which include peppermint and caraway, and it's actually been around since the 1950s. There have been a lot of studies looking at Iberogast, and the figure I'm showing on the top is from a meta-analysis of 3 double-blind randomized control trials that involved 273 patients. And they looked at the data for the most bothersome symptom in these trials, which could have been cramping, pain, nausea, fullness. And they found that at the end of the intervention, the most bothersome symptom remained severe and very severe in the placebo group in 26%, but only in 7% of the Iberogast group. Now, the heat map on the bottom shows a cluster analysis looking at how each herb may help with the pathomechanisms thought to be involved in functional dyspepsia. What I like about this is that it shows that because functional dyspepsia is a heterogeneous condition, it may be more likely to respond to a multi-target treatment like Iberogast than to a single target treatment like an antiemetic or an antispasmodic or an antibiotic. So the bottom line is this is an over-the-counter option, which costs about $30 a month, and it may be worth a shot in your patients, not the ones who are losing weight and going to the ER, but maybe the ones who are just persistently bothered by satiety, fullness, and abdominal discomfort. Now let's move on and talk a little bit about nausea and vomiting. I'm not going to talk about gastroparesis here because that's a talk in and of itself, but I want to start off by talking about the differential for nausea and vomiting. So I see a lot of patients for quote unquote refractory nausea and vomiting who actually complain more of regurgitation than vomiting. So if you have a patient who says that immediately after swallowing they're vomiting food, that's much more likely to be an esophageal problem than a gastric one. You can start by getting an esophagram or potentially even a manometry or pH testing based on the situation. The other thing to consider in these patients is rumination, which is characterized by the effortless regurgitation of usually normal tasting food during or soon after eating. These patients can do well with diaphragmatic breathing, which is a low risk option that's worth considering whenever you think this might be a possibility. And lastly, before settling on the diagnosis of chronic unexplained nausea and vomiting, consider cyclic vomiting or cannabinoid hyperemesis syndrome if there appears to be a cyclic nature of the vomiting episodes. Now, for those patients who do have chronic unexplained nausea or even explained but hard to treat nausea, I want to highlight a neuromodulator called Mirazapine. So this medication actually affects a number of different receptors, which is why it has anxiolytic and antidepressant properties. But what I'm highlighting here is that it affects the 5-HT3 receptor very similarly to ondansetron and granisetron, but has a longer half-life and is much cheaper. And through its actions on other receptors, it also helps with things like insomnia and promotes weight gain, which may be a pro-con based on the clinical scenario. The typical dose is from about 15 to 30 milligrams at night. And in the right patient, so someone with nausea, who's losing weight, maybe having trouble sleeping, this is a great option. Another highly effective treatment for nausea and vomiting is aprepident. So aprepident is an NK1 receptor antagonist. The neurokinin 1 receptor has a dominant ligand that's called substance P, which is found in really high concentrations in the vomiting center of the brain. Aprepident prevents substance P from activating the NK1 receptors and is shown to be highly effective in inhibiting both acute and delayed emesis from cytotoxic chemotherapy. Now, in 2017, a large multi-center randomized control trial called the APRID trial was done in 126 patients with gastroparesis and chronic unexplained nausea and vomiting. They were treated with 125 milligrams of aprepident per day for 4 weeks. While the trial didn't reach its endpoint, its primary outcome, which was reduction in nausea based on a visual analog scale, it did show significant reduction in symptom severity of nausea, vomiting, and retching based on symptom scales like the PAGI-SIM and the GCSI score, which are the graphs I'm showing here. It can be really expensive, with one 125 milligram pill costing over $300, and insurance coverage outside of chemo is a challenge. But for inpatients or those who are able to afford it or get coverage, it can be really effective. Now I'd like to switch gears and talk about the use of psychological therapies and antidepressants for the treatment of IBS. I'm not going to go too deep into the data for therapies like CBT or antidepressants because I think by now most of us are aware that these therapies work for patients with disorders of gut-brain interaction. What I'm showing here is data from 2 well-done meta-analyses looking at these treatments. The graph on the left is from a meta-analysis by Laird and colleagues looking at 41 randomized control trials of psychotherapy and IBS. And you can see across the board, the aggregate favors treatment. On the right is another well-done meta-analysis by Ford and colleagues looking at 12 randomized control trials of antidepressants. And you can see that the number needed to treat for tricyclics was 4, and the number needed to treat for SSRIs was 3.5. So how do these therapies work to treat GI symptoms? In the interest of time, I'm not going to go through the structural equation modeling shown here, but suffice to say, it showed that CBT improved GI symptoms directly, not through an intermediary of improving psychological distress. Similarly, in terms of antidepressants, while it makes sense that antidepressants might help by addressing comorbid mental illness, a large body of work suggests this isn't the case. The quote you're seeing on the slide is from a Cochrane review by Sardo and colleagues from 2007, looking at antidepressants for neuropathic pain. They identified 61 trials, of which depression was a variable in 18, and they concluded, the quote here, there appears to be no correlation between depression and pain relief. They found that antidepressants produce analgesia in patients with and without comorbid psychiatric illness, suggesting that improved mental illness doesn't explain the benefit in most cases. So if these treatments don't work by improving mental health, how do they work? Let's talk about the pathophysiology of pain. So pain starts with primary afferent neurons from the periphery being activated by noxious stimuli and sending a message to the dorsal horn of the spinal cord, which is right here. So here's your noxious stimuli going up to the dorsal horn of the spinal cord. In the dorsal horn, projection neurons get input from a lot of primary afferent neurons and send signals up to the higher brainstem, and to the higher brain centers. And this is where this conscious experience of pain is created. In addition, there are descending pathways, which is the green line here, that synapse on the dorsal horn projection neurons and modulate pain signals at that level. At each point in this pathway, the pain signal is susceptible to modulation to either dampen it or amplify it. And in some cases, an exaggerated or prolonged response to noxious and ultimately non-noxious stimuli can develop. And this is called central sensitization. So the lightning bolts that you're seeing here, so the red, double red arrows are showing the augmentation, and the lightning bolts are showing you all along the way that you can develop this central sensitization. While there are a lot of great analogies to help understand central sensitization, one that I like is about tickling. So I have two little girls who I love to tickle, and after a few good bouts of tickling, I find that if I just get close to their faces and I wiggle my fingers and I say, "I smell tickles," they'll burst out laughing. And the more I tickle them, the more ticklish they get. I don't even need to tickle them for them to laugh. And this is just like pain and central sensitization. For some people, pain signals get amplified to the point that a peripheral stimulus is no longer even needed to cause pain, and that's central sensitization. So how does this relate to IBS? As we all know from clinical experience, there are a number of common syndromes that present with pain hypersensitivity without a clear explanation. And more importantly, these conditions tend to occur together, far more than would be expected by chance. So multiple epidemiologic studies have shown that clinical entities like chronic fatigue, fibromyalgia, interstitial cystitis, migraines, and disorders of gut-brain interaction tend to occur together. This suggests that there's a common mechanistic basis for these diverse conditions, and it may be that central sensitization is that mechanism. So let's zoom back into what's happening on a neuronal level. On the left, you can see a representation of the descending inhibitory opioidergic, noradrenergic, and serotonergic pathways that modulate pain signals from the dorsal horn. On the right is a schematic of connections in the dorsal horn of the spinal cord. So you can see a primary sensory afferent neuron, which uses an array of neurotransmitters to communicate to the projection neuron, which then transmits that signal to the higher brain centers where this conscious experience of pain is created. You can also see a descending neuron. I'll highlight the noradrenergic pathway, as this is where a lot of pain neuromodulators work. So here's the NE for norepinephrine. And what you can see is that norepinephrine inhibits neurotransmitter release from primary afferents, right here at the alpha-2 adrenergic receptor. And it also inhibits signaling at the postsynaptic alpha-2 adrenergic receptor on the projection neuron. So this noradrenergic action prevents signals coming from the GI tract, for example, from reaching the brain and being interpreted as painful. So how do these medications work? Descending inhibition acts physiologically to mask perception of irrelevant nociceptive input from digestion or joints or muscles. So it may be that in conditions like IBS or fibromyalgia or interstitial cystitis, descending inhibition is impaired, causing the perception of pain from otherwise normal peripheral processes. An SNRI boosts norepinephrine signaling, which inhibits these inputs and may allow them to once again be ignored. On the right is a schematic of how alpha-2 delta ligands like gabapentin and pregabalin work to modulate pain. In order for neurons to release neurotransmitters, voltage-sensitive calcium channels need to be activated to allow the flow of neurotransmitters. Repetitive action potentials, which are the lightning bolts here in the presynaptic neurons, can lead to prolonged opening of these calcium channels, which then leads to prolonged release of neurotransmitter, and then excessive stimulation and action potentials in these dorsal horn neurons that then project to the higher brain centers. So this excessive stimulation may, over time, lead to central sensitization. Medications like gabapentin and pregabalin, which are kind of showing here, block these channels, block the neurotransmitter release, and block that development of central sensitization. Now, before I get into a few specific neuromodulators, I think the most important tip I have today is about how to talk to patients about neuromodulators. The first point is related to the idea that pain can be in the brain, not in the tissue. In other words, pain may not be an indicator of a problem, it may be the problem. The analogy here that I'm borrowing from an amazing neuroscientist and pain expert named Lorimer Moseley is the check engine light. So when the check engine light comes on in your car, it may indicate a problem with the engine, but if you get the engine checked out a couple times, everything looks normal, it might actually be a problem with the wires of the check engine light itself. The second point is to highlight that the medications we're going to talk about are neuromodulators, not just antidepressants. inevitably patients are going to find out that these medicines are antidepressants as a class. So it's better to address this at the beginning. My usual comment to patients is that these medications are used to treat a number of different conditions, from migraines to seizures to depression to pain, and that I'm using them in this case to fix a miscommunication between their gut and their brain, not to treat mental health issues. The last point on this slide is about setting expectations. For patients with hard to treat symptoms, it's important to say that you may not be able to get them pain-free, or to have a completely normal bowel pattern, or to the point where they can eat anything they want whenever they want it. But what you can say is that in the vast majority of patients, you can get them better than they are at that time. I think the other thing to be clear about, especially for those who may be a bit more in the land of the worried well, is that they have to decide what's more bothersome, their symptoms or the potential side effects of medications to treat those symptoms. So now on to the neuromodulators themselves. I know this is a super busy slide and I'm not going to go through all the details here, but I wanted to highlight a few key points. I listed the medicines here in the order I think would provide the greatest utility in practice. In other words, if you're new to using neuromodulators, I'd start by learning about and trying nortriptyline. On the other hand, if you've already dabbled with tricyclics and SNRIs, you might want to think about adding pregabalin or olanzapine to your arsenal. So for a high-level overview, I'll start with nortriptyline. So it's a tricyclic, it's good for pain, diarrhea, and cyclic vomiting. It's less likely than the other tricyclics like amitriptyline to cause anticholinergic side effects, drowsiness, and weight gain. It very, very rarely can prolong the QT, so it's good to monitor EKGs, although it's unlikely you're gonna see a lot of change. Duloxetine is an SNRI that helps with pain, and it's better for those with constipation compared with tricyclics. It can cause nausea, but that often gets better with time. Escitalopram is an SSRI that's good for constipation and anxiety, but not pain. The SSRIs are not good for pain, but of the SSRIs, escitalopram might be the best tolerated. Moving to the next column, pregabalin is an alpha-2 delta ligand that helps block those calcium channels we just talked about. And so it's very good for pain, especially central sensitization style pain. It's more potent and better tolerated than gabapentin. And the last two here are olanzapine and quetiapine, which are both atypical antipsychotics. They're both used to augment tricyclics and SNRIs in the treatment of pain, but they can cause sedation and weight gain. The other thing to know is that olanzapine is quite effective at treating nausea, similarly to mirtazapine. So a quick note on augmentation. Augmentation refers to adding a second neuromodulator when treatment with the first is either not completely effective or when dose increases are limited by side effects. These are probably the least utilized amongst gastroenterologists, but low doses at night can absolutely help take someone who's seen improvement with a tricyclic or SNRI, but either hasn't been able to tolerate dose escalation or has plateaued in their response to the next level. Note that the doses of olanzapine and quetiapine that are used for augmentation for our purposes are much less than what we would use to treat psychiatric conditions, and they have a very low risk of causing the extrapyramidal side effects that people associate with antipsychotics. This is the last slide in this section, and it's from a great article on neuromodulators that was published in Gastro in 2018 by Doug Drossman and colleagues. The top section talks about the first-line neuromodulators, the SSRIs, SNRIs, tricyclics, and tetracyclics like mirtazapine. The bottom section highlights the agents that are useful for augmentation, including the azapirones like buspirone, which we talked about, the delta ligand agents like pregabalin, and the atypical antipsychotics that we just talked about like olanzapine and quetiapine. Note that other augmenting options are things like hypnosis, mindfulness, or diaphragmatic breathing, which is where I'd like to spend the last few minutes of my talk. So Nerva is a gut-directed hypnotherapy app for your smartphone. It was developed in conjunction with Dr. Simone Peters, who's a hypnotherapist at Monash University in Australia. In 2016, she published data from a randomized control trial that I'm showing here, showing that 6 weeks of weekly in-person gut-based hypnotherapy showed similar improvements to GI symptoms compared with the low FODMAP diet, and that effect was sustained at 6 months. Now, Nerva isn't an in-person hypnotherapy, it's a pre-programmed app, but it's a similar protocol and idea, and it has potential benefit with minimal downside. There's a free 7-day trial that patients can check out, and then the six-week program costs $70. As a physician, you can actually send them a message and you can get free access if you want to look at it a little bit more yourself. In terms of mindfulness, there are many apps out there, but my favorite is Headspace. It's a comprehensive mindfulness program with hundreds of meditations covering everything from pain to insomnia to coping to anxiety. It's a bit more involved, but it's worth it for motivated patients. Breathe to Relax is an app that guides patients on how to perform diaphragmatic and deep breathing. And it also has some education sections talking about how breathing helps with stress. And the last one I'm going to talk about is Belly Bio. It's a similar app in that it helps with diaphragmatic breathing, but it has a really ingenious biofeedback mechanism where patients can place the phone on their lower abdomen and the phone will play music if it tilts in a way that confirms that they're actually breathing with their abdomen as opposed to their chest. So to conclude, educating patients about the gut-brain interaction and setting expectations is key. We're in a new era of neuromodulation for the GI tract. So if you haven't already, pick one or two of the neuromodulators we discussed today and start using it in your practice. You'll be amazed by how quickly you start feeling comfortable and seeing results. Remember, start low, go slow, but keep going and keep adding. Don't stop at a low dose if you don't see a response. And consider adding an augmenting agent if you've made progress, but aren't quite there yet or are running into side effects that limits further dose escalation. Lastly, there's an app for everything. The few I've highlighted are ones that I like. There are a dozen others out there in the field of mindfulness, relaxation, breathing, CBT. They're low risk, convenient, and patients love them. Thanks again for your time, and I'm happy to take questions.
Thank you very much for a very comprehensive talk. We do have a few questions. One is, in a patient with comorbid psychiatric illnesses, is there anything that you worry about in terms of maybe starting a TCA first line, or do you prefer to work in conjunction with a psychiatrist if you don't have a lot of experience with neuromodulation?
I mean, I think it's always good to work with a psychiatrist, and if a patient has a psychiatrist, I definitely think, you know, it makes sense to say to them, this is what I'm thinking about, talk with your psychiatrist, or picking up the phone and talking with their psychiatrist. I think in terms of nortriptyline specifically, you know, if a patient has comorbid depression or anxiety, I think nortriptyline is reasonable. But even if they don't have any of that comorbid condition, I think it's a good one to start with because it tends to be well tolerated. You can start at low doses. You know, people often have trouble sleeping, so it helps with sleep. And you can dose it by level. So if you feel like you're not getting a response, you can check a blood level and see if you're in a therapeutic window. And if not, you and the patient understand that maybe you need to go up. And if you are, you may say, okay, that's not the right one. Let's augment or switch.
Great, thank you. Another question we have is, do you incorporate acupuncture into your practice? And for which patients would you think about that for?
Yeah, absolutely. I mean, I think acupuncture is right in that line with hypnosis, mindfulness, breathing, cognitive behavioral therapy. All of these complementary and alternative pathways are great. I think acupuncture is really good for nausea, and I think it can be really good for pain. I think the biggest trouble with acupuncture is, like all of these therapies, it's finding a practitioner who you know and can work with. I'll say that acupuncture is like many forms of therapy. You know, not all acupuncturists really have a good protocol for GI acupuncture. And so I think trying to find that person that can work with you, that has worked with patients that have gastroparesis or that have chronic abdominal pain can absolutely be great.
Thank you. Another question is, you know, bloating seems to be one of the harder symptoms to treat, especially in someone who maybe doesn't have food-related intolerances or SIBO, and you think visceral hypersensitivity is the cause of their bloating, and they don't seem to respond as well to neuromodulation. And do you have any kind of options in terms of treating those patients?
Yeah, I think bloating is a tough one because it, you know, on the one hand, it's discomfort, but you're right, it's not that classic pain. You know, I do think things like Buspar can help with bloating. But the other thing is I really like the GI hypnotherapy for patients with bloating. I think that they respond really well. You know, one of the things that you can see with patients with bloating is that there can be this vicious cycle of hypervigilance and then hypersensitivity, and they're focused on the bloating and they feel more bloated, and the more bloated they feel, the more they're focused on it. And I think hypnotherapy really helps with that. But similarly, if you have a good therapist who's good at cognitive behavioral therapy and coping skills, I think that can really help draw down that hypervigilance, which can decrease that sensitivity.
Thank you for that. And How do you approach an underweight patient, particularly a younger patient? Maybe they have comorbid eating disorder, and if you have any tricks regarding that.
Yeah, so a couple things. One thing I think is really important is I see a lot of young people nowadays who have these comorbid ARFID, so that's avoidant restrictive food intake disorder. And I think it's important when you see young patients and their BMI is 18 and they're saying that they can't eat because they have all these symptoms, but that may be a sign of this more behavioral pattern of ARFID. And I think talking to patients about it, destigmatizing that, and involving your psychiatric colleagues is helpful. I also think, though, that some of the medicines we talked about today are really good for helping with appetite and weight gain. So mirtazapine is really good for nausea and helps with appetite and helps with weight gain. Similarly, olanzapine, which is Zyprexa, I know that's kind of the scary one, that's the atypical antipsychotic, but really low doses of that at night can really help boost people's appetite and boost weight gain. So I think those are two good neuromodulators to kind of keep in your back pocket for these underweight patients.
What do you tell your patients about probiotics, particularly if they bring it up for IBS or bloating?
Yeah, probiotics is sort of a tough one. I think that there's good data that probiotics, no specific one, but that probiotics tend to help people with irritable bowel. But I think that we're missing something here, which is that a couple things. The first is, you're basically saying you have billions of bacteria, thousands of different kinds, and we're going to give you one, and somehow that's going to make a difference, right? Like that to me doesn't seem to make sense, and I think that will be borne out over time with more data. I think the other thing is that probiotics can make things worse. So when you think about people who have SIBO, putting in more bacteria, even if it's good bacteria, is not necessarily going to help. And there's a little bit of data that's starting to come out about how some bacteria, even good bacteria, can produce lactic acidosis and actually cause more gas formation, more bloating, and maybe even brain fog. So if I have a patient who's come to me and they're already on probiotics and they feel like it's helping, I usually won't stop it unless it's very clear to me that we're dealing with SIBO. But I have to say that I don't initiate that many probiotics in my practice because I do think that there's this opposite side where it can make people worse that maybe is under-recognized right now.
Do you test for CSID?
Yeah, I do. I tend to test for it in people who kind of have the classic bloating dyspepsia. I've tried the FODMAP diet and maybe they got a little bit better, but not as much as I would expect. Then those are the patients who I'll look for sucrose intolerance.
And then I think the last question we have is, where do you direct your patients to get Iberogast from?
You can get it on Amazon. I bet you can.
Everything's on Amazon, right?
Yeah. I mean, I have no stake in the company, but yeah, you can get it there.
Well, thank you very much for a very illuminating talk, and I think an important one, and we really appreciate it.
Thanks.